Assalamu alaikum. I'm Dr. Abdul Kiyo. Today, my topic of presentation is non-neurogenic lower urinary tract symptoms. Our learning objective is epidemiology, symptomatology, and IPSS, UFM, and post-void volume. Introduction. The term lower urinary tract symptoms encompasses a range of irritative storage and obstructive voiding difficulties. The phrase is purposefully gender non-specific and does not presume anatomical site of origin for the symptoms. Storage symptoms is urgency, frequency, nocturia, and urinary incontinence. Voiding symptoms is hesitancy, intermittent urination, straining, poor flow, and post-maturation symptoms is post-void dribbling and sense of incomplete emptying. There are many causes of fluids, starting from benign prostatic obstruction, detrusor underactivity, detrusor overactivity, nocturnal polyuria, chronic pelvic pain syndrome, neurogenic bladder dysfunction, UTI, foreign body in urethra or bladder, urethral stricture, bladder tumor, and distal ureteric stone. There are many definitions of lower urinary tract symptoms: interruption in the urinary stream, frequent urination, especially at night, hesitation before the beginning to urinate, a feeling that bladder is still full after urinating, and terminal debris, an urgent need to urinate, and weak urinary stream. Polyuria, urine output of more than or equal to 2500 ml during a 24-hour period. 24-hour urine volume is more than 40 ml per kg. Body weight is called polyuria. Two possible causes of polyuria is diabetes insipidus and diabetes mellitus. Nocturnal polyuria, increase in nighttime urine production with decrease in daytime. Nocturnal volume is more than 6.5 ml per kg or greater than 35% of total 24-hour urine volume is nocturnal polyuria. Possible causes is disruption of diurnal secretion of arginine vasopressin or reverse in nocturnal and diurnal urine production, sleep apnea, congestive heart failure, lower extremity venous stasis, bladder storage problem. Nocturnal bladder capacity index is more than 2, is low nocturnal bladder capacity. Possible causes is bladder obstruction, bladder overactivity, sensory urgency, infection, inflammation, interstitial cystitis, and malignancy. Nocturnal polyuria, there are many causes of nocturnal polyuria: heart failure, overactive bladder, diuretic medication, antihypertensive medication some people use, alcohol and coffee intake, diabetes insipidus, benign prostatic hyperplasia, and excessive water consumption.
Okay, now my question to Dr. Kaushal. Dr. Kaushal, when the patient comes to OPD 14 and he says कि मुझे पेशाब में जलन होती है और पेशाब बार-बार आता है, so the next thing that we do is ultrasound full bladder post-void residual urine DRCS. Now, after going through the previous slides, now what are your thoughts on how to evaluate such a patient? Hello?
So, first of all, we have to evaluate the history part. and like or yeah, yeah, like like and after properly taking the history and taking her from the picture and then how they can proceed for and how they will proceed for investigation like yeah, and
Okay. So, Arslan, what is the moral of this story? Should we go? What I was asking is that in OPD 14, we have a knee-jerk reflex that we go for an ultrasound urine DR. He's rightly said that before all these investigations, we miss a lot of things. So, what is the moral?
First of all, patient age is most important, and then the comorbs, as well as the concern history is most important, and then we go for the examination. When we are talking about history, then first from the age, and then the comorbids, if he is diabetic or not, and then is he has recently any history of infections and any other urological procedure done previously, as well as neurological history is also part of this. And after evaluating these things, and just to rule out the what is the main cause of this, is this storage symptoms, voiding symptoms, and then we will go for the storage as well as the voiding, and we will further elaborate it by in storage symptoms is the frequency, nocturia, and rest of intermittence, incontinence, as well as obstructive symptoms. And then after these proper history, we can differentially diagnose that this patient is leading towards the any obstructive pathology, or any other. So on this basis, then abdominal and perineal examination for especially external genitalia, and then we will move for the investigations. Start from these baseline investigation, in which also part of urine CS, serum creatinine, and then ultrasound. And this is the we were discussing post-wide, as well as if indicated, then we go for the UFM and other.
Yes, that's very fine, very fine. So, what I'm trying to tell you is that most of the time the culture is not and it does not show any pathology, and the bladder is being emptied, and we say no urological intervention, but it's such is not the case. Okay, now you need to lower tract is not so simple that a simple ultrasound or a culture can rule out of storage or obstructive symptoms. The first thing that you should put in mind that the lower tract needs a very good history. It needs history, it needs excessive information on the behavior and the fluid intake of the patient. If a 60-year-old patient comes to you with dysuria and nocturia, the first thing that comes into your mind will be prostate. But when you investigate him for the prostate, his prostate, his stream is all right, he is all, but he has hypertension and his diabetes. So do you think hypertension and diabetes can increase the urine output? Yes or no? No. Yes. So before you go into surgical causes of lower urinary tract symptoms, you have to make sure that the medical causes are optimized. If his hypertension is controlled, he has normal behavior of urine. Diabetes is controlled, normal behavior of urine. Other than renal failure, cardiac failure, his things are controlled. Then you can evaluate whether his nocturia, polyuria, his frequency is due to urological cause. So whenever a patient of LUTS come into your OPD, it's the best way to practice the history is to give a little time to that patient and ask him about his lower tract symptoms. Now, what is to ask? We will discuss in the following slides. Next is Sakar. Sakar, I will be asking the questions from you.
Symptomatology, urinary incontinence, involuntary passage of urine, stress incontinence, involuntary passage of urine with any activity that increase intra-abdominal pressure, urge incontinence, involuntary passage of urine coincident with the sensation or urinary urgency, mixed urinary incontinence, patient have the urinary urgency with loss of urine and loss of urine with Valsalva minor, continuous incontinence, constant wetness in the perineum that is independent of the urge to urinate or minors, associated with increased intra-abdominal pressure. Pseudo incontinence, some female patient experience symptoms similar to continuous urinary incontinence but fail to demonstrate true urinary incontinence. Overflow incontinence occur when the urine within the bladder exceeds the bladder capacity. Intravesical pressure is more than urethral outlet resistance. Functional incontinence, patient with limited mobility and limited access to the toilet. They have intact bladder outlet anatomy and physiology may experience incontinence. Enuresis, urinary incontinence during sleep is called enuresis. It usually present in 15% of the child up to 5 years of age. History is most important. Maybe the patient present in OPD with the Lutz symptoms have diabetic mellitus, any history of urological intervention, history of hematuria, previous episodes of urinary retention, burning maturation and febrile UTI, drug intake, and constipation.
Now, Dr. Amar from Sakar, please tell me, in the history there is a questionnaire called the International Prostatic Symptom Score. Can you please tell me about the IPSS and its importance?
The IPSS is designed to inquire about the lower urinary tract symptoms, and it's like grading from 1 to 5, and how much bothersome for the patient.
What are the 7 questions that you ask this patient?
Like about frequency, urgency, and hesitancy, and about the stream, and incomplete bladder emptying, and nectoral and necturia.
These are 5. Okay, let's ask someone else. Anyone who can tell me the IPSS score confidently? This is the IPSS score. The IPSS score is the core of low urinary tract symptoms. आप उसके बगैर आगे चल ही नहीं सकते without this.
And IPSS score is basically comprises on 8, and in first these are the symptoms, and one is the question related to the quality of life, and it starts from 0 till 35, and when we say that 0 is asymptomatic, and from 1 to 7 is the mild symptoms, and 8 to 19 are the moderate symptoms, and from 20 to 35 these are the moderate symptoms. And these are questionnaire already described by Dr. Amar, that we have 7 questionnaire and we ask, and on these basis we further score these IPSS, and this these are written in different languages, in Urdu, Sindhi, in English, and comprises on the storage and widening and
So that is very well said. But what are the questions? You are sitting in OPD 14. Today is Thursday. Some of you will go to the prostate OPD. Someone will come to the stricture OPD. Someone will do OPDs on Saturday.
I will.
So, what question you will ask, male or female?
I will ask about the frequency, urgency, nocturia, enuresis, intermittency, hesitancy. Uh,
What are those 7? आगे बढ़ना ही नहीं है ये जब तक साथ है बैठ जाओ मैं हमजा सियाल तुम्हें आता है 7 questions IPSS मैं आगे बढ़ूंगा ही नहीं
Frequency,
क्लासेस 2 दिन में कर देंगे
frequency, urgency, intermittency, straining of urine, incomplete bladder empty,
नहीं
posting.
frequency नहीं
Urgency.
May I tell, sir?
IPSS देखिए questions I'm asking you questions आप कैसे पूछेंगे
There are 3 questions which show your storage symptoms, and 4 of them are more related to the voiding symptoms. The first 3 are frequency, urgency, nocturia, which show more towards your storage symptoms, while the 4 questions of voiding symptoms include straining, weak stream, intermittency, and incomplete bladder emptying.
मतलब मुझे ये समझ आ रहा है कि आप मरीज से पूछेंगे अस्सलाम वालेकुम आपकी फ्रीक्वेंसी ऑफ यूरिन क्या है आपकी इंटरमिटेंसी कितनी है आपकी वीक स्ट्रीम कितनी है आपकी नॉक्चूरिया कितना है तो जवाब दे पाएगा
सर उनको अगर
देखिए why I'm stressing on IPSS is because no one is asking in the OPD. We used to ask a long time back. It's very important. It gives you those who are in the practice of taking the IPSS, they understand one thing that this gives you some direction to where the patient's lower tract symptom is going. ठीक है ना? And you can base this. If you give a patient on alpha blockers, आपके पास क्या रैशनल है कि आपने उसको अल्फा ब्लॉकर स्टार्ट किया सिवाय दैट ही हैज एन एनलार्ज्ड प्रोस्टेट ठीक है बट एनलार्ज्ड प्रोस्टेट डज नॉट मीन दैट ही हैज एन ऑब्स्ट्रक्टिव स्ट्रीम कोई और भी साइंटिफिक रीजन होगा ना
सर इसमें हम यही स्टार्ट करते हैं कि जी आपको कितनी दफा पेशाब के लिए जाना पड़ता है आपको बहुत जल्दी दफा तो नहीं जाना पड़ता बाज दफा ऐसा तो नहीं होता कि आपको जाने से पहले ही पेशाब आपका निकल जाए और रात में आपको पेशाब के लिए कितनी दफा उठना पड़ता है कोई आप सोने से पहले कुछ कोई चाय कॉफी जूसेस तो नहीं लेते और आपको कितनी दफा आपकी रात में नींद डिस्टर्ब होती है आपको उठ के वॉशरूम जाना पड़ता है और फिर हम ये बोलेंगे कि जब आप पेशाब करते हैं तो आपको जोर तो नहीं लगाना पड़ता और जब आपको पेशाब करने से पहले आपको जोर तो नहीं लगाना पड़ता या बीच में आपका पेशाब रुक के नहीं आता और पेशाब करते हुए आपको जलन या दर्द महसूस तो नहीं होता तो ये बेसिकली 3 और 4 को बोला वही स्टोरेज और ऑब्स्ट्रक्टिव वाला ये है सारी ये चीजें इनको मिला के हम 7 क्वेश्चंस को
थोड़ा सा रहम खा लेते हैं ठीक है ना देखें if you are doing OPD 14 and as a resident you do not tell your senior who comes to see your patient what the IPSS score is वो तो पास हो गया है but you are definitely lacking behind कि आपने IPSS स्कोर एक पेशेंट आ गया सर ये प्रोस्टेट को पेशेंट है इसको मैं थर्सडे OPD बुलाऊं आप कम से कम अपनी उसके लिए IPSS जरूर बताइएगा ये मैं इसलिए स्ट्रेस कर रहा हूँ कि अगर इफ यू प्रैक्टिस इट राइट नाउ व्हेन यू कम नियर द एग्जाम तो दुआएं देंगे मुझे ठीक है ना तो लेट्स सी द IPSS स्कोर एंड आई विश एंड आई प्रे दैट यू मेक इट अ पार्ट ऑफ योर एक्टिविटीज ऑफ योर क्लिनिकल ट्रायल्स ठीक है ना चलिए सो जी अब आप कहीं थोड़ा डिटेल में इनको बताएं एंड दीज आर द क्वेश्चंस दैट यू शुड आस्क एंड इट इज नॉट डिफिकल्ट टू एनालाइज what is the scoring system if you get into the habit of asking the IPSS you will know whether this patient is falling in the mild moderate or severe criteria ठीक है you'll automatically get a judgment but these are the questions that you should ask
International prostate symptom score and quality of life score there are 7 components of IPSS. Question number 1 is over the past month, how often you had a sensation of not emptying your bladder completely after you finishing urinating. There are 5 grades, not at all, 6 grades, less than 1 time in 5, less than half of the time, about half of the time, more than half of the time, and almost always. The second question is, over the past month, how often you had to urinate again less than 2 hours after you finish urinating? This is frequency. And same grading will be applied. Over the past months, how often you have found you stopped and started again several times when you urinating? Intermittency. Over the past month, how often have you found it difficult to postpone urination? This is urgency. Over the past month, how often have you had a weak urinary stream? The sixth question is, over the past month, how often you had to push or strain to begin urination? The question number 7 is, over the past month, how many times did you mostly typically get up to urinate from the time you went to bed at night until the time you got up in the morning? And this is 1 time, 2 times, 3 times, 4 times, or 5 times. More than 5 times is grade 5. And quality of life scoring, if you were to spend the rest of your life with the urinary condition just the way it is now, how would you believe about that? Delighted 0, pleased 1, mostly satisfied, mixed, unhappy, and terrible. Okay, this is quality of life score.
ठीक है. Now, the catch of IPSS is that this is a questionnaire that should ideally be given to the patient. He reads this question and ticks the most appropriate boxes. अब आप लोगों के दिमाग में सवाल ये होगा कि सर ये सवाल पूछे कैसे, ठीक है ना? तो I'll give you an example just with this hope that you involve this in your practice. Number 1, the one thing you have noticed in the IPSS, all the questions are relating to a duration of 1 month. तो मरीज से आप पूछते हैं कि पिछले एक महीने में जब आपने पेशाब करना शुरू करते हैं तो आपको क्या पेशाब शुरू करते वक्त जोर लगाना पड़ता है? तो कहते हैं अगर वो सेज यस तो कहते हैं क्या हर वक्त लगाना पड़ता है, कभी कभार या ज्यादातर कम? तो यू गेट अ अप्रोक्सीमेट आंसर. उसके जब आप पेशाब शुरू कर लेते हैं तो क्या जो धार बनाते हैं वो उसकी मोटाई पहले से कम हुई है, पतली होगी, कैसी है? कहते हैं हाँ, इफ यस देन हाँ, क्या ज्यादातर पतली रहती है, कभी कभार आती है, या मतलब कभी आपने देखा या नहीं देखा? देन यू गिव अ नंबर. उसके बाद जब आप पेशाब कर लेते हैं तो क्या आप महसूस करते हैं कि आपने पेशाब पूरी तरह से खारिज कर दिया या कुछ पीछे रह जाता है? तो ही विल से यस और नो. अगर यस है तो देन यू आस्क हिम कि कभी कभार, ज्यादातर रहता है या कम? जब आप पेशाब कर लेते हैं तो दिन में कितनी दफा पेशाब करने जाते हैं? ही विल गिव यू अ नंबर. अच्छा, रात को जब आप सो जाते हैं तो पेशाब की हाजत की वजह से आपको कितनी दफा नींद से उठना पड़ता है? ही विल गिव यू द नॉक्चूरियल नंबर. जब आप पेशाब ऐसा करते हैं तो ऐसा तो नहीं होता कि झटकों में आता है, शुरू होता है फिर रुक जाता है, शुरू होता है फिर रुक जाता है, नहीं होता. Then the last, after you assess these seven questions, then you ask the it. कहते हैं अगर हम आपका कुछ भी इलाज ना करें या अभी अगर आपके पेशाब को इस हालत में रहने दें तो आपकी तबीयत कैसी रहेगी, आपको कैसा लगेगा? He'll give you an answer. तो ये जब आप सवाल पूछ लेंगे तो you can see whether he has more of irritable symptoms या more of storage problems. ठीक है ना? ठीक है. Or does he have anything which is in the urine? So you can bring it down to bladder outlet obstruction, either neurogenic cause, non-neurogenic cause, which can be prostate, which can be stricture. Now, do you understand why I've spent so much time on the IPSS score? This is for all the residents. आप IPSS score, even FCPS के वाइवा में भी score नहीं बताएंगे, they will not proceed forward. वो कहेंगे खिलाड़ी अभी कच्चा है. ठीक है. So all those who are in the residency program, अभी से habit बना लें, क्योंकि these questions To handle these questions, they need time. अब मैंने आपको जितना आराम से बोल दिया इसलिए क्योंकि we have practiced it for a very long time. अगर आप शुरू करेंगे तो आपको थोड़ा सा देखना पड़ेगा फिर पूछना पड़ेगा. So everything. So this is how important the IPSS score, examination point of view and clinical point of view. समझ गए? Any questions? तो फिर हम आगे चलते हैं.
Pseudo incontinence so
Classification. Well, pseudo incontinence classification है क्या? बहुत कम देखा है मैंने भी कोई खास इस पे इतना नहीं पता.
साइकोजेन कि वो कहते हैं कि यूरिनरी इनकॉन्टिनेंस मुझे होती है लेकिन वो कुछ अगर एग्जामिनेशन कर लें तो उनका एयर पेरिनियल रीजन वेट नहीं होता लेकिन वो पेशेंट को ऐसा फील होता है.
मोस्टली फीमेल पेशेंट्स के अंदर ट्रू एंड फॉल्स कॉन्टिनेंस इनकॉन्टिनेंस को वो करने के लिए जब आप उनसे हिस्ट्री ले रहे होते हैं तो उसमें एक टर्मिनोलॉजी होती है सूडो कि ये देखने के लिए कि इज इट इज जो पेशेंट बोल रहा है कि क्या वो वाकई में उसको कांस्टेंट पैसेज ऑफ यूरिन है या नहीं. तो उसको करने के लिए वो जो एक इम्प्रेशन सा होता है वो उसको जो कि होता बेसिकली डिसकॉन्टिन्यूटी ही है, कोई कॉन्टिन्यूस नहीं है, तो वो उसको जो फीमेल्स के अंदर तो वो उसको सूडो इनकॉन्टिनेंस की टर्मिनोलॉजी में होगा.
I think it's a very. I haven't seen such a. मतलब I've read the terminology. It's there, but diagnosis of pseudo incontinence has been very rarely made in clinical practice. I think it's a diagnosis of exclusion. When all other things have been exhausted and then the patient still complains of some continence not seen either physically or on the radiological examination, I think it's a diagnosis of exclusion. Very rarely, over the practice of I think the last 6 years, I haven't seen anyone with this diagnosis of pseudo, but it's there as a terminology, and it's a terminology from the Incontinence Society. So it's there in the books. So we have to see it.
IPSS, when there is 0 point, the patient is asymptomatic. Mildly symptomatic, the points is 1 to 7. Moderately symptomatic, the points is 8 to 19. Severely symptomatic, the points between 20 to 35.
Okay. Now, when we've gone through the IPSS score, you have come to this score. Either he's mild, he's moderate, or he's severe. Now, Arslan, in mild, if a 68-year-old male comes with prostate, you calculate the IPSS score, he has mild. But our practice is that when we see he has a prostate of 32 grams without taking the IPSS, we start on tamsulosin, which is an expensive drug with side effects. So, but if a person calculates the IPSS, he comes out to be mild. Do you think he requires tamsuline? Whereas it is recommended in mild IPSS, you can observe this patient. You can see how it progresses. Whereas in moderate, you have your scientific background to give tamsulosin. And in severe, then you have other options, surgical included. So now do you understand कि tamsuline किसको देना है? तो tamsuline उसको देंगे जिसका IPSS पता होगा. IPSS नहीं पता होगा तो you do not have any scientific background to give tamsulosin or an alpha blocker. Just because, ठीक है? आप अगर दिल पे हाथ रख के बोलें तो आप अल्फा ब्लॉकर इसलिए देते ना कि प्रोस्टेट एनलार्ज आया ओपीडी 14 में और थर्सडे को देते हैं ना. तो इफ यू कैलकुलेट द IPSS एंड मतलब हम तो बेदरक लिख देते हैं ना. सो इफ यू कैलकुलेट द IPSS and if that enlarged 38-gram prostate in a 68 male falls into the mild symptoms, and then you can control his other comorbids like hypertension, diabetes, fluid modification, behavioral modification before prescribing an expensive drug like an alpha blocker. Do you understand the science, what I'm trying to teach you? All the residents. ठीक है ना? तो number one, prostate का मतलब नहीं है कि tamsuline दे दिया. ठीक है? You need to see the IPSS score and scientifically build a background in which you are going to give a medical treatment which has advantage and complications to the patient. तो आपको सेटिस्फाई करना है, ठीक है?
Frequency volume charts and bladder diaries. The recording of volume and time of each void is referred as FVC. Frequency volume charts. Inclusion of additional information such as fluid intake, use of pads, activity during recording, and grades of symptoms of severity and bladder sensation is called bladder diary. Bladder diary is kept for 48 to 72 hours. It gives the insight into functional capacity of the bladder and help the quantify the severity of nocturia. This is a frequency volume chart. The time, how the intake, how much fluid intake, and urine volume of urine, how urgent the urine. This is severity of urgency. Leakage. The bladder diaries also show the incontinence symptoms, leakage with urgency, leakage with activities, and pad change. The volume of incontinence or the quantify of incontinence.
Anyone knows the importance of the frequency volume chart? What information can be gathered from the frequency volume chart? We have all done pediatrics. Can you assess the bladder capacity? Can you assess the daytime volume? Can you assess the volume at night? Can you assess the total volume that is voided? You can do it from the frequency volume chart. And then the incontinence. If there is incontinence before urination, there is some sort, then you can have a clue, maybe it can be urgency. If there is incontinence after urination, that is another thing. ठीक है ना? If there is incontinence most of the time, another diagnosis. ठीक है ना? So those who have the habit of seeing the frequency volume chart can bring out information from this FVC chart. It's just not a chart to see the educational status of the patient, but rather to impart his bladder behavior in a non-invasive way to the doctor, and he can then come out with some problems. ठीक है ना?
Clinical examination, abdominal examination, examination of suprapubic area and genitalia, and rectal examination. PR examination, normally prostate is firm and smooth with palpable sulcus. Signs of BPH, enlarged firm prostate with the palpable sulcus, and hard nodular surface with impalpable sulcus is the sign of malignancy.
Dr. Kaushal, you had a question?
Going back to the previous slide regarding this frequency volume chart, it's mentioned how urgent 0 to 3, and 3 is the most urgent, 0 is no urgent. Say, then regarding 1 and 2, and how are you going to interpret it and use in a clinical decision making about this point?
How much has been measured in mLs? When you give a frequency volume chart, you give a calibrated container to the patient where he drinks water, and when he passes the urine, it's a calibrated container and he measures it. Like we measure the bladder capacity in cystoscopy. It's a calibrated container. So how much is the ml that he has voided in every urine? The volume of urine, that is what I'm talking about. And how much that he has drunk, one glass is 150 ml. Okay, but if you want to be more sure, you can give him a calibrated glass. So how much of his drink? If the cup of tea that we have here is about, I think, about 100 ml. So these are sort of subjective knowledge that you have. Small cup is 100 ml, a glass is 150 ml, a big glass is 250 ml. So these are some things that you can tell the patient. For the volume in ml per second, in ml. So that is from a calibrated beaker. He urinates into a beaker and he measures the urine output. How urgent, 0 to 3, this is the patient's subjective assessment. It is variable. Some might consider 3 to be very urgent. Some may consider that 3 to be 2 in another patient. It's his subjective his assessment. It is different patients, but that is the patient's subjective assessment. ठीक है ना? Does that answer your question?
Sorry, sir. Actually, I mean, like, suppose someone is saying, okay, like, I have urgency and I have to run quickly. Like, I can't hold at all. Within few seconds, I have to run. So if I score it 3, and someone say, okay, I can control for few seconds, but I have to run. Like sort of moderate sort of thing, I can score 2, and I have to run, but okay, I can control. Maybe sometime I can control. Maybe sometime I miss. So 1. So how you interpret it in your clinical practice? Like what it signifies exactly?
The answer to the question is in your response. It depends on how urgent. For example, a patient who feels the urgency. A patient who feels the urge to go to the washroom but can hold it for say about 5 to 10 minutes, complete his work and then go to the washroom. That is, you can regard it as 1. But a patient who has urgency, that he has whatever he is doing, whether it is important or not, he has to leave it and go to the washroom, otherwise he will leak. You can regard that as 3. So, but this is something that the patient will tell you how severe it is. They usually give a response like you have given, that how urgent it is. Then they give, no, it's not that bad. So you can keep him in the middle too. ठीक है ना? Okay. Okay, next question. Dr. Hamza Syal from Sakar. उधर ही है? चले गए? Okay. और कौन बैठा हुआ है? चलो, सलमान है ना शायद. Salman, tell me the importance of DRE and your experience in clinical practice.
The importance of DRE is it gives to us whether there is a large prostate or not, or whether there is some like malignancy, and whether there is obstructive symptom due to enlarged prostate or not.
Okay. Anyone else? The importance of DRE, their experience. Should it be done? Should it be not done? उससे कुछ information मिल जाती है.
In DRE, it's basically tells us about the behavior of the prostate. By the tactile sensation, we can give idea that is enlarged prostate, normal prostate, or there is any nodularity, or it's indicating an prostate. But new guidelines suggest that TRUS is more important than this DRE. For the volume only.
About the incontinence. Is it due to sphincteric instability or something?
Clinical examination is done to give you a direction towards your investigation. ठीक है ना? Trust will, but DRE में सिर्फ आपको prostate का तो पता चल जाएगा, but he has pointed out, Jalal has pointed out very important thing. You can know about the anal tone. If it's a neurogenic lower urinary tract symptoms, you'll expect a decreased tone in the sphincter. So that is a part of the DRE examination, that you have to quote the sphincter tone. Then you do the DRE. You see the characteristics of the prostate. You see how enlarged the prostate is. Whether it is tender. If it's tender, he has some sort of prostatitis going on. If it's hard, then you can see, instead of you can have some idea that he might be having something of a cancer of the prostate. If it is benign, you can have an assessment how large this is if you're thinking towards surgery. So a practice of DRE in our institution. It has been superseded by the trust, but for the residents, they have to have this practice of DRE because you are required to perform this in the FCPS exam. ठीक है ना? Unless you have been excused not to do it. So when it is going to be done in your FCPS exam, I would suggest that you practice it and you gain your experience from doing DRE, so that when the exam comes up, you can through reflex analyze what information this prostate is giving you through the DRE. ठीक है ना? So what I'm trying to tell you is that do not leave the things, but as a resident, your objective is to proceed towards the exam. These are very basic things. जो अगर आप ना करें तो फेल हो जाएंगे, कर देंगे तो शायद कोई फाइंडिंग मिल जाएगी, शायद नहीं मिल जाएगी, but it will set a good impression on the examiner and it will make your clinical examination more robust. ठीक है?
Regarding the enlargement, how large is it? How to quantify, like, clinically in a...
There are two ways. One way was being done when I was in residency back in Rawalpindi. They used to say that if the prostate is up to the first phalanx of the index, you can feel it. It's say about 30 grams. If they say if it's up to the middle phalanx, it's about 50 grams. And if you can't feel the other end of the prostate, it's more than 80 grams. Subjective. There is nothing totally logical about it. It's just a subjective experience. Now the second thing is what we do is mild, moderate, and severe enlargement. Again, a very subjective. If you feel that the enlargement is not too big, it's mild. If you see that no, it's through experience, it's bigger than the previous prostates, you can label it as moderate. And if you cannot feel the upper end of the prostate, it's a very grossly enlarged prostate. It is subjective, but the size is one of the features of the prostate, but you see other things as well. Overlying mucosa, median sulcus, those are more important. The consistency of the prostate, the tenderness of the prostate, the anal tone. So all these together hold the value. You can just say that it's an enlarged prostate. To me, it feels mild. But if I put in the finger, I might say, no, Kaushal, it's a moderately enlarged prostate. If I ask Arslan to put in the finger, he might say, no, sir, I think it's a grossly enlarged. So it's subjective, but the bottom line is that it's an enlarged prostate. You feel an enlargement of the prostate. Okay.
Investigation, urine analysis, serum creatinine, post-void residue, and UFM. Recommendation for the diagnostic evaluation of male-lets: take a complete medical history from men with LUTs. Use a validated symptom score questionnaire, including bother and quality of life assessment during the assessment of male LUTs, and re-evaluation during and after treatment is strong strength. Use a bladder diary to assess male LUTs with prominent storage component or nocturia is a strong strength. Tell the patient to complete a bladder diary for at least 3 days is a strong strength. Perform a physical examination, including digital rectal examination in the assessment of male LUTs is strong strength.
Okay. Now you've seen the recommendations. Piche, slide piche. You've seen the recommendations. जो भी सारी बातें हमने पिछली 1 घंटे में की हैं, they all have a strength rating of strong. So we have strongly discussed these symptoms. So there was a reason why there was given so much time to these symptoms, because they're all strong recommendations. Strong recommendations mean that they need to be performed by every physician who is every urologist, and if it's not done, then he is going against the recommendations. ठीक है ना? So I hope you understand why we had such a long discussion. So it's going to be a long discussion. Lower tract. I'll request the academic area to give me another class, because we'll proceed after investigations. We're almost out of time. So I would like you to go back. We've just discussed the history of lower urinary tract symptoms. It took 1 hour just to discuss the history of lower tract. We have not even come to the investigations. So we'll save it for another day, and I'll request we get another class for it. So I hope you can now at least start practicing the history. Sir, thank you.